Hi, I'm Dr. James Riley, and I'm here to talk to you today about the medical and psychological concerns with international adoptions. I'm one of the doctors of AdoptionEducationClasses.com, and I'm a general pediatrician in Long Island, New York. The harm of institutions. When I talk to people about children who live in orphanages, one of the things that I think that it's hard for them to understand is that orphanages really are not a good place for kids to live. Usually, the problems are as follows. They can have poor nutrition. One of the things that usually we'll see in orphanages is that the kids will not have the best food in the world. They don't have a variety of food. Food costs money, and usually it's the kind of thing that they're going to be fed food which is nutritious but really just sustaining, not having all the vital micronutrients that children might need. And some children will need more nutrients than others, and those are the kids who usually will see having problems with the diet that sometimes is seen in several orphanages. They'll have developmental delays. They'll have the effect of emotional neglect, meaning that children are made in this way so that way they can have a mother who takes care of them. If they don't have a mother that takes care of them, they're not actually going to grow normally as we would expect another child to grow, and they're going to have actually sequelae from that. They'll have increased exposure to infections, or what I would call like the Chuck E. Cheese kind of syndrome, where children who are going to be around a lot of other kind of children, usually they're going to get all the different kind of various illnesses that you're going to see in kids who are in daycares, etc. They're going to have the lack of a medical advocate, which people don't realize that having a mother who actually knows what's right for a particular child is very important. Usually it's the kind of thing that a mom will be able to know when something is really not quite right with a child, and they'll bring them to see me. A lot of times I see that in my private practice, where the mother doesn't really know what's wrong, but something is just wrong. And we'll actually find children have actually serious diseases just on the mom's hunch. Unfortunately, there can be places where sexual predators or people who abuse children will actually go. So usually this will be one of the things that usually the doctors who see these kind of children will actually be looking for, looking to see if they have any signs of physical or sexual abuse. They can have various infectious diseases. Any orphanage anywhere in the world, children will be exposed to various infectious diseases. They will have developmental delay, as we said. Unfortunately, several children will be exposed to alcohol while they were inside their mother's womb. As we know that alcohol, a toxin, which can affect brain growth. So unfortunately, we'll see this where actually children will have sequelae for the rest of their lives because of the alcohol that they'll have been exposed to. Post-institutional syndromes. Unfortunately, when you're inside an institution, there are several things that can happen to you. The immunization status is one of the things that we'll be looking at. Many of the places where we'll see children from, their immunizations are not very trustworthy, that when we actually check to see if the children produced antibodies from the vaccinations that they were given, we find that actually they didn't produce antibodies from those vaccinations, meaning that the vaccination did nothing. So it was almost as if they were never vaccinated. So usually this will be one of the things that usually you'll need a pediatrician to kind of figure out. They'll need to know which countries have good vaccines and which ones don't. We'll have to look at the lab tests. In reality, not every country is as good as the United States, which has people to look at their lab tests, make sure that they're done the right way. So we'll have to look to see how does these lab tests compare to the tests that are done in the United States. Alright, so when should I see my friendly neighborhood pediatrician? Usually we'll see them about 10 to 14 days after they've been in this country. We don't want to bombard them with a lot of tests right after they got off the plane. So usually after they've come into this country, usually we let them bond with their parents a little bit, and then hopefully we'll be able to see them about 10 to 14 days later, unless they have some urgent medical problem. Certainly sometimes a child will be, wheezing or have high fever on the plane, and then obviously they have to see a doctor right away. But we'll usually just do a very kind of quick assess to see what's wrong with them, and then bring them back for our full kind of evaluation. Some people, when they come into this country, they believe that the visa exam, the exam that they had to come into this country, is a full, comprehensive physical, and that they've discovered everything that there is to know about this child. But in reality, these are just very quickie kind of physicals. It's the kind of thing they're just checking to make sure that they're not going to bring some contagious disease into this country. So they're just going to be checking to make sure, for example, that they're not going on the plane with chickenpox or bring Ebola virus or something like that. Usually when they come into this country, they need a very careful medical evaluation. So what does that mean? Like, for example, I had seen a child who had a medical visa and had all the medical exam for their visa and all these kinds of things, and had been examined in their country by pediatricians. And when they came to see me for their first exam, I noticed that one leg was very significantly longer than the other. So I had to send them to the orthopedic surgeon. This, you might say, is something very easy that anybody should be able to pick up, but unfortunately this is one of the things that we'll see when we see a child come from another country. Growth failure. Usually we'll see this in basically every single kid who's internationally adopted. What we see is about 1 month delay for every 3 to 4 months that they're inside an orphanage, and usually we'll see very rapid catch-up growth. In fact, if we don't see very rapid catch-up growth, this is really a huge red flag that there must be something wrong, because it is the kind of thing that almost every single kid usually grows phenomenally once they're given our kind of Kentucky Fried Chicken / McDonald's laden American diet. So we have to be very careful when we see a kid who's not really growing the way that they should be growing. We must figure out what's going on with them. Usually when they're inside the orphanages, they're not going to grow the same because they're not having that same very calorie-dense, nutritious food that they're going to get when they come to the United States. They're not having the nurturing contact that a mother might give to a child. They're going to have other kind of issues that are associated with orphanages. So, for example, sometimes a child might be in an orphanage, might be cranky, hungry, complaining more, crying more, and then the orphanage might see that as something being almost like neurologically wrong with the child, so they'll actually prescribe the medicine to sedate them, so that way they don't cry as much. So you could see that perhaps now they won't cry as much, so then no one will listen to their hunger cries. That's better, I guess, if you were inside the orphanage, but not better for that particular child. Again, like I said before, usually we feed these children and they usually grow better. Sometimes, if they don't grow better, it can be due to different problems, such as medical problems. It could be due to the way we're trying to feed them. Some of these children, they're not being fed textured kind of foods when they're in the orphanage. So what does that mean? That means that they're used to like very fine kind of foods, or they're being fed from a bottle. An easy way to feed a child would be to cut the hole in the nipple, put the food inside a bottle, prop it up, and let the kid suck the food out. So you could see someone who's done this their whole life, they don't know how to eat from a spoon, and they'll be very resistant when you offer them a spoon for the first time, and they may not grow the way they've been growing. Usually if we kind of offer them the food, usually they'll do okay, but some kids will need actually the intervention of a speech therapist, some other professional. So this will be one of the things that usually we'll be looking at. Short stature. Usually we'll see short stature in virtually every child, and usually again it'll be because of the poor nutrition. Now, sometimes this won't be something that's due to the poor nutrition. Sometimes it'll be a sign of a medical kind of problem. How does a doctor figure this kind of stuff out? Well, one of the ways we figure this kind of stuff out is if we actually see that the kid is actually much shorter with respect to their height than to their head circumference or to their weight. If it seems like that the height is more severely affected, then usually this has something to do with something that's going to be affecting their growth. So this will be one of the things that we'll be looking at. But normally it's the kind of thing that if we kind of feed the child, then we'll see that their short stature will resolve and they'll actually get bigger. But again, if we feed them and they don't grow, there usually is something going on there. It's the job of the doctor to figure that out. Microcephaly. Microcephaly basically means small head. So micro means small, cephaly means head. But usually docs like to make everything seem a little bit complicated. So usually microcephaly basically just means small head. And it has been said that bigger is better, and when it comes to head size, definitely bigger is better. And what we're talking about when I have a kid with a small head is that normally a tall person would have a little bit bigger head in relation to their body, so that they were proportionate, right? A smaller person, smaller head, smaller height, smaller weight, everything should be nice and proportionate. Sometimes we'll have a child, small head, but it's like the rest of their body is bigger than it should be for its head. When this happens, then what we figure out is that is there something genetic going on? Is this just that everybody in the family has a small head, or was there something going on in the baby that made their head not have to grow? Meaning, like, perhaps their brain didn't have to grow, or their brain didn't grow at the rate it should have grown, and that's why their head is small. So you could see that's why when we see someone with a small head, it's a very worrisome kind of sign. We need to figure out what's going on when we see a child with a smaller head proportionate to the rest of their body. What are the reasons that kids can have small head? Well, it can be, like we said, some genetic kind of problem, some malformation, toxins such as like alcohol, and it could be an infection that the mother had when she was pregnant. They could have had some hypoxia, which means that they didn't have enough oxygen go to their brain. Their brain couldn't grow that well. It stayed a small size in relation to the rest of their body. Their body didn't need the oxygen as much, kept growing. And then you see that's why sometimes they can have a smaller head, and that would be bad if their brain didn't have enough oxygen, that it impaired its growth. Placental insufficiency, basically they're getting their oxygen from the placenta, so if there's something wrong with the placenta, then there's going to be something wrong with the oxygen, so they have a smaller head. They could have a metabolic or degenerative disease. Post-adoption catch-up growth, and you can see from this picture that a kid can come into this country, be incredibly emaciated, incredibly thin, and then after a few short months, they look like any other kid that you'd find in any daycare or any playground in the United States. Tuberculosis. Tuberculosis is common in all the countries that provide children for international adoption. Unfortunately, tuberculosis is one of these things that we see all over the world. Tuberculosis is spread through the air, so it's spread usually from an adult who's sick, who doesn't realize that they're sick, and they're coughing. These little particles actually pass among the children, and then unfortunately, because they have poor immune system and they're living in crowded conditions, usually they're going to get sick. Unfortunately, also is that a lot of times people who grow up in these countries, they've received the BCG vaccine. Now, a lot of times they think that because they received the BCG vaccine that it's impossible for them to get tuberculosis, but this is actually not true. BCG vaccine does not protect them from getting tuberculosis. The only thing BCG vaccine does is it actually protects them from having it spread into their brain, which is a good thing, right? But it's the kind of thing that it doesn't protect them from really getting tuberculosis. So, unfortunately, what we have is a population of people who believe because they were vaccinated they shouldn't be able to get tuberculosis, and they also believe that when they come to this country and they get tested for tuberculosis that they're always going to come back positive. But this is not true, right? It's the kind of thing, the reason why they come back positive for tuberculosis is because they grew up in a country where tuberculosis is endemic, and it's the kind of thing that they all have been exposed to tuberculosis. And the other thing about tuberculosis is that once you're exposed and it's inside of you, it can be actually decades before you actually see the sequelae from this disease. So this is our problem, that we have these kind of people who might be telling prospective parents that not to listen to the positive PPDs, but it's actually something very incredibly important, because tuberculosis, especially when it starts to grow in a child, it can actually go to their brain, kidneys, bone, and it can cause problems that really we may not be able to fix for you again. Usually the good thing is that when the kids come to this country, they don't have active disease, meaning that they can't spread it to other people. They just have the bacteria inside of them, or the microbacteria inside of them. It's the kind of thing that it is important to catch them in this stage. This is when we want to catch them. So the idea is that we'll do a PPD, which is a test for tuberculosis. We'll do it in them when they first arrive, and then 6 months later, after their immune system has started to pick up, we'll test them again. Again, the BCG vaccine is not a contraindication to the PPD. If we just saw that they just had the BCG vaccine, then perhaps we might delay a few weeks. But really, other than that, we're not going to do anything. If we have any idea that the kid may have actually active tuberculosis, meaning tuberculosis that's found at home in some part of their body, then we're going to do an imaging study to figure out how active it is. So if it's going to be in the lungs, for example, we'll do a chest x-ray. Does this actually really happen, or is this a theoretical kind of problem? Well, in 1999, there was a 9-year-old boy who was adopted from the Marshall Islands, and he infected 56 people, 20% of his contacts in North Dakota. HIV infection. HIV infection, unfortunately, a worldwide kind of problem. Luckily for us, not a huge problem in the internationally adopted children. These children are usually screened for HIV prior to being placed for adoption. The testing may or may not be reliable, and usually it's the kind of thing that we can always test them again when they come into the United States. But really, having a child being infected with HIV now is exceedingly rare, unless we already know that they have HIV. Usually this has gone down since we realized that HIV can be spread through needles, so now usually almost every orphanage, really, they use individually wrapped needles. The practice of reusing needles has gone by the wayside. There are different kind of tests, but certainly to test for HIV you're going to need a doc, so really it's just important that your doc know what kind of tests are important. Congenital syphilis. Congenital just means that it's syphilis that they picked up from their mother, right? So the problem with syphilis, and for a lot of the other diseases that we're going to talk about in the coming slides, is that a lot of times that I can see this child and see nothing on physical exam that leads me to believe that they have picked up an infection. So for example, for syphilis, there are physical findings that when I see a child I can get the idea that they have syphilis, but in reality these are very rare. Most of the time when we see a kid like this, we're not going to see anything. They're going to look perfect. We're not going to see any kind of signs or changes or anything like that. But it's very, very important that we check them to see that if they've been exposed to syphilis in utero. So what are the tests that we're going to do? Again, you probably will need a doc to do these kinds of things. Unfortunately, if syphilis is missed, if it's never been tested for, it can cause changes that we can never fix for you again. So it's just important that we test for it. Usually to treat it, we just give penicillin and we can knock it out of you. Intestinal or skin parasites. Some of the more common skin parasites: lice, scabies. For those of you who unfortunately or may have not been exposed to lice, lice basically look like little seeds, like sesame seeds, and they kind of move if you find them inside your hair. Scabies are something that you may not be able to see in the skin, but usually it's going to be an incredibly pruritic, itchy rash that you're going to see mainly in the skin folds, and you might find them in between the fingers or in the wrists and things like that. So this is the part of the talk where almost everybody starts scratching themselves and things like that. Usually it's extremely common in places where people are living in close quarters. So for example, scabies is very common to see in nursing homes. And of course in orphanages, this is going to be a place where we're going to see lice and scabies. Intestinal parasites, Giardia, probably the most common infection that we're going to see. Giardia is an intestinal parasite and very often can be something that causes wasting. Wasting meaning that the kids will not gain weight. Even though we're giving them a nutritious diet, they seem like they're eating okay, but for some reason they're not getting it. You could think of it almost like, I think most people are more aware of like tapeworms or some other kind of intestinal parasites, but Giardia is actually the most common thing. Most of the time when we find Giardia, not really causing the kids too much problems, but it is something that can cause kids big problems, and unfortunately they can have it and not have any diarrhea, not have anything that you would think that you would have when you have an intestinal parasite. Usually to find out if you have Giardia, you're going to need a doctor to do some tests. Usually it's going to be stool tests. And we have medicines to knock it away, so usually it's not a problem. Hepatitis B. Hepatitis B is a virus which affects your liver. Unfortunately, kids who are born with hepatitis B, having caught the hepatitis B from their mom, who obviously must have been infected with hepatitis B, they are more likely to have what we call hepatocellular carcinoma, which is the cancer that you might get from hepatitis B infection. Kids who are born with it are more at risk for this. They're also more at risk to have what we call chronic hepatitis B, meaning that hepatitis B that doesn't go away, and then they have for the rest of their lives. So as you can imagine, this is something like exceedingly important that we actually test for. Once again, we may not see any signs of it, but it could be something if they pick up hepatocellular carcinoma or they have chronic hepatitis B and they're going to be infectious for the rest of their lives. That would be something that we would need to know. The risks are again going to be because they might have shared needles, although unlikely. It could have been person-to-person spread. It could have been picked up from the mother. Hepatitis B is something that can be sexually transmitted, so you can imagine that the same way the mom could have picked up syphilis and then found themselves pregnant and then had to give the child up for adoption. It's the kind of thing that a lot of times kids may be picking up hepatitis B in the same way, that the mothers, again, unprotected sex, picked up hepatitis B, and then they have to give up the child for adoption, and now the child has hepatitis B. Hepatitis C, similar to hepatitis B, it can cause a chronic kind of disease. It doesn't actually cause any cancers, but it's also more of an indolent kind of infection, an infection that there really will be zero signs that the kids have this infection, and yet it can lie in their side of their body, quietly causing damage to the liver and eventually destroying the liver. It can take about 16 weeks before the tests come back positive, and it can be passed through blood transfusions. Unfortunately, no physical findings, as we said before, and can only be tested for. It cannot be seen on physical exam. Fetal alcohol syndrome. What is fetal alcohol syndrome? Basically, it's this, is that alcohol is one of these things that it's a toxin for our bodies. I think we all know that. When a mother who is pregnant drinks alcohol, this alcohol passes very effectively into the unborn baby. The alcohol then does its effects. Now, because the baby is developing, it can actually cause maldevelopment in different parts of their body. So it can cause the brain to maldevelop and different parts of their body to maldevelop. But of course, brain is the most important thing. Unfortunately, there is fetal alcohol syndrome, which sometimes we can actually see a picture or a video of a child and get an idea if they've been exposed to alcohol. There is also something known as fetal alcohol effect, meaning that they can have the effect of the alcohol and yet it didn't actually occur at a time, or it wasn't significant enough to cause the facial stigmata, meaning the changes that normally we might see in the face or in the body that clue us in to this being a person or a child who is going to have problems with fetal alcohol syndrome. It is probably one of the leading causes of mental retardation. What are the facial features that we're going to see? Well, we can see a small head, flat mid-face, a thin upper lip, meaning that this part of the lip will be thin. Sometimes we'll see that the philtrum, which is this little line right here, will be actually completely flat. They can have a short nose, small chin, low nasal bridge, minor ear abnormalities, or epicanthal folds, meaning these kind of folds over here in the eye. A lot of times we can see different kind of changes, like a small mid-face. They can have actually these kind of things, what we call railroad track ear, where we can see these different folds come in two linear formations that look like almost like tracks of a railroad. And this is just another picture that just shows the flat philtrum, meaning that they don't have this part of their face right here. Usually, what are the neurologic manifestations? They can manifest, of course, developmental delay, because if their brain has been affected, then their brain is not going to function the same as everybody else's. So, whereas someone else is able to say words at a specific time, they're not going to be able to, because their brain is not going to work as good as people who haven't had exposure to alcohol when they were in utero. They can be seemingly having attention deficit later on, or they can have features of attention deficit. They'll be hyperactive, they'll have poor short-term memory, they can have coordination problems, poor impulse control, short attention span, sensory hypersensitivity. As infants, they can be hyperexcitable and have poor sleep-wake patterns. One of the other things that we have to worry about kids who grow up in an orphanage is that we know that these are places which are magnets for sexual predators. So this is one of the things that we're going to have to examine them very closely for, see any signs that they've been sexually abused. Fractures, abuse, and rickets. I'm not sure if people know too much what rickets is, but basically sometimes through poor nutrition, the bones will not form the same way that they should be forming in kids who have adequate nutrition. So what happens is that sometimes the bones will form and curve in a very characteristic way, and usually what you will need is we'll need a doctor to be able to look at the child and be able to see if the bones are actually forming in a way which is characteristic of what we call nutritional rickets. Usually when we see kids with rickets, they don't actually have a lot of the bony abnormalities, but they can have some of the changes in the blood that show that their nutrition wasn't adequate, and they're actually starting to see these changes in their bones. This is usually going to be something that we can change, or we can fix, I should say, but it's the kind of thing that it's one of the things that you don't know if it's happening sometimes unless you're actively looking for it. So this is one of the things that we're going to have to look for. Usually it's the kind of thing we may see fractures because their bones are poorly mineralized. and because that perhaps that they have not been exposed to vitamin D or haven't been outside and haven't been able to form vitamin D because of sun touching their skin, and they're going to have poorly formed bones because of that. Their immunization status. Most of the children will have received some immunizations, but as we were stating before, it's the kind of thing that's not all immunizations are created equal. And unfortunately, in certain countries, we'll see certain things where the vaccinations, for example, if they're not kept at a proper temperature, they lose their potency. Losing their potency means that they're not going to be able to produce as much antibodies as you need to protect you from the infection. Now imagine you have a vaccine that's not that potent. You have a kid who is not going to be producing a good immune response anyway because they have poor nutrition. It's a setup to have a vaccine that's not going to work and is not going to give them protective antibodies. So what happens is then we think that they're not going to get, for example, whooping cough because they received the vaccine for whooping cough in their country. And yet, if they're exposed to whooping cough, they get sick because their antibodies were not protective. So this is one of the things that usually a doc has to figure out, whether or not they have protective antibodies, whether or not it's reliable from their country that those antibodies should have been picked up. How malnourished were they? Do you think that it was something where they were so malnourished that we can't reliably say they picked up their antibodies? A lot of things to consider, a very difficult kind of situation for docs. Sometimes the problem for us is this, is that we look at the immunization record and we say, the kid was born in October, and yet it says that they got vaccines in September. How reliable is this? It's the kind of thing, is the birth date wrong, or is the vaccine date wrong? Or is this vaccine record from another child who was next to them? When you see a situation like this, it becomes very hard to trust the vaccine. So it's the kind of thing that we have to actually look at these things very closely and with like the eye of a detective, look to see if everything is coming out the way it should be coming out. We have a few choices. Usually either we can trust the vaccines that they got from their country, or we can actually just restart the entire vaccination schedule depending on what we see. Sometimes we can do is we can check their blood when we're checking blood for other things, for example for rickets. We can check their blood and actually check them for antibodies, and if they seem to have protective antibodies, then we can leave them alone with certain vaccines. This is a fairly complicated list, but basically shows all the medical conditions that we might see: post-traumatic stress, HIV, prematurity complications, chronic infections, physical abuse, mental deficiency, depression, chronic ear, milk intolerance, genetic syndromes, fetal alcohol syndrome, rickets, sexual abuse, hernias, malnutrition, premature birth, developmental delays, attachment disorder, scabies and lice, learning disabilities, mental retardation, parasitic infections, vision and hearing problems, respiratory problems, basically almost everything that you could have. So what are the screenings that we do post-adoption? Well, this is a fairly comprehensive kind of list. Usually these are all the tests that are recommended in the Red Book, which is basically the Bible for infectious disease in children. And you can see that we are fairly going to suck them dry, and then we're going to take a lot of blood out of them. But really all these things you can see are very important kind of things in checking for a child. How do we minimize the institutional effect after adoption? Meaning that how can we optimize them when we finally get them? We know that we have all these kind of sequelae from being an orphanage, but how can we make their transition as smooth as possible? Well, we can avoid overstimulation. Remember, these are children who they grow up in an orphanage. They're not exposed to a lot of different things. There's an overwhelming sameness every day. So all of a sudden, they're coming to a new country, being exposed to new language, they're exposed to new people. That's a lot of change. Now if all of a sudden everything is beeping and blinking and different things, they have toys that talk to them and different things, these are going to be things that are going to be very overwhelming for them. They're not going to handle it very well. So we'll try to avoid overstimulating them. Some people, they're so filled with love for their new child that they want to do everything they want for them. So they think of other children they know and they say, oh, children love to go to Disneyland. Let's take them to Disneyland right away. This is like the worst place that you could take a kid. This is like torture for a kid who's lived in the same blue-gray walls every day for their whole life. So usually what we're going to want to do is put them in a bare room, basic, not too many things to stimulate them. We want to have a structured routine. Human beings like to wake up at the same time, go to sleep at the same time, go for a walk at the same time, eat at the same time. These are the kind of things that are going to allow them to bring order to their life and bring more structure to their world. We want them to be exposed to parents. Remember, this is one of the big deficits in their lives, that they don't have a kind of consistent caregiver. Sometimes we'll see a kid who the parents have used up all their time off just to adopt the child. So as soon as they get the child into this country, they're shifting the kid into daycare right away, and they have no time left to spend any significant amount of the time with the child so they can bond. You know, we may not have any time left, but we have to find the time. We have to create the time, because this is one of the things that are going to be very important for the child. First impressions mean a lot, so it's the kind of thing that our first impression should be that our new parents love us and are going to spend time for us and value time with the child more than anything. So this is one of the things that we really encourage people to do, that their first caregiver should not be nanny and the people in the daycare, and then we pick them up and then put them to bed right away. We try to communicate as much as we can in their native language. Certainly it should be easier for us to pick up a few words in their native language than for them to have to learn everything in English. We try to limit TV, not too much TV, but if we give them TV, we try not to give them anything that's going to be too stressful. Try to give them only the most mildest of TV shows. Allow bonding. Usually it's the kind of thing that they're kind of bonding deprived, so they need extra bonding more than other children. Usually it's the kind of thing that once you adopt a child, everyone's going to want to give you toys. But we don't want to give them every single toy that they are being given on day one. Slow introduction of toys, new things. This is going to be better for the children in the long run. We try not to take them to the mall and a lot of confusing new places, especially in the beginning. Slowly we can bring this kind of things into their lives, but we try not to have it happen on day one. If they're of age, we try to enroll them in school, and we try to teach them the same way that we would teach any child. We try to have them earn activities and privileges, give them discipline and order for their lives, because kids are, of course, much happier knowing what they can and cannot do. If we let them do anything, even if they know that they're not supposed to do it, they're not going to be happy. So in conclusion, institutional or foster care is no substitute for a loving family, and there are possible long-term effects from being in a foster care or in an institutional kind of setup. Children may have experiences in their background in early life which put them at risk later in life. So when we, for example, see an internationally adopted kid and they're 8 years old, one of the first things we do is we see how are their relationships with their peers, how are their relationships within the family, how are they doing in school, is there anything in their schoolwork or in their social life that makes us think that they're having any sequelae from their previous experiences. Growth and developmental delay are basically universal, and it's the kind of thing that we expect that there should be some delay, but we also expect that they should kind of go away with time. If they don't go away with time, and if they don't get better, then it is our fault. We have to figure out what's going on, and we have to fix it. Early intervention, rehabilitation, and a loving family will help the children to lead a normal life. Alright, and then that's it. You've completed the video portion of this talk. If you want to get credit for it, then you just go to the quiz portion, which you'll be able to find. If you don't want any credit for it, and you're just doing this for your own edification, then I guess you're done, and you don't have to do anything else. Alright? Thank you for your attention. Again, I'm Dr. Riley, and have a nice day.